Thank you for the kind invite to both the organizers, Dr. Amita Maheshwari and Dr. Dabar. Basically, what I'm presenting today is both on small aspects of bevacizumab with or without addition of intraperitoneal chemotherapy to a backbone of chemotherapy and a backbone of bevacizumab. So this was presented by Joan Walker, and few slides on background. We know that we still give paclitaxel and carboplatin at these doses to most of our patients with ovarian cancer. Paclitaxel carboplatin has been established for the last 15 years. As Dr. Rajiv pointed out, the Japanese Gynec oncology trial showed that adding paclitaxel at 80 milligrams per meter square every week, that is giving it in a dose-dense fashion, adds overall survival benefit to patients over and above what we get with our conventional paclitaxel regime. So that was something that showed benefit. The other study that showed benefit was the GOG 172 trial, another landmark paper where intraperitoneal chemotherapy was used. Very few patients, actually less than 50% of patients completed the intraperitoneal chemotherapy protocol there, but the intraperitoneal chemotherapy arm patients did significantly better with better overall survival. This is in spite of almost 50% of patients, more than 50% of patients not finishing the protocol as planned. So again, there was a survival benefit. So these are two trials that showed survival benefit in the last 1 decade in ovarian cancer. Anti-angiogenic agents, the background has been given by Dr. Rajiv. Trials have already been done, and consistently when you use a VEGF agent, an anti-angiogenic agent, there is a progression-free survival benefit in the first line. However, this does not translate into an overall survival benefit. So whether the first line use of a VEGF agent is justified has always been questioned. So there are more and more trials into looking how to optimize the use of an VEGF agent in the first line. So this is just to summarize what I have said till now. Intraperitoneal chemotherapy, there seems to be benefit. Dose-dense paclitaxel, like on the Japanese Gynec oncology protocol, yes, there seems to be benefit. But like my colleague mentioned, the MITO 7 trial that came from Italy did not show the same benefit, but the final publication is still awaited. And bevacizumab has shown progression-free survival benefit. This is the GOG 172 schema, just 2 slides to show the differences. They used both paclitaxel and cisplatin in an intraperitoneal schedule. The paclitaxel came on day 8. That is one of the criticism was whether it was actually a dose-dense paclitaxel schedule given intraperitoneally rather than just an intraperitoneal chemotherapy benefit for these patients. Showed benefit in the whole population, but it is still used very, very sparingly. It's not really used very often. At least we do not use it in our practice. I don't know how many centers in India use it. And although the hazard ratio for survival was significant. Dose-dense weekly, again, just one slide. He's already shown there is definite benefit of adding paclitaxel in a weekly schedule rather than a 3-weekly schedule. Sorry. The GOG 262 schema has been discussed, so I'm not going into that, but not great benefit. The benefit actually is for patients who have not received bevacizumab but have taken the chemotherapy on a weekly schedule. So discussed by the last discussant. So with this, the GOG 252 schema is actually for stage 2 to stage 3 epithelial ovarian cancer, resected to optimal less than or equal to 1 centimeter visible by the surgeon as per the surgeon's decision. And the arms included paclitaxel at 80 milligrams per meter square, week 1, day 1, day 8 and day 15, and AUC6 carboplatin with bevacizumab 15 milligram per kg on day 1 beginning from cycle 2 up to maximum of 22 cycles. Arm 2 had the same chemotherapy arm and bevacizumab with a bevacizumab maintenance, and carboplatin was given at AUC 6 intraperitoneally on day 1. So this is a carboplatin intraperitoneal arm. The third arm had paclitaxel in IV schedule, but at a lower dose at 135 milligram per meter square, not at the usual dose. And cisplatin was given at 75 milligram per meter square. Again, the dose was 100 milligram per meter square in the GOG 172, the previous study, with Bev and Bev maintenance. So the questions asked were, of course, with the standard arm of dose-dense paclitaxel with bevacizumab, which is the standard arm here, whether IP carboplatin added to a dose-dense Taxol had benefit, whether IP cisplatin had at a slightly reduced dose, and all three arms, of course, included bevacizumab. So goal of this study was to improve the acceptability of IP chemotherapy. It was intended to improve chemocycle completion, because the completion rate in GOG 172 was very poor, less than 50%. Ease of utilization with an outpatient regime if possible. And if you look at the median PFS, whether it was an IV carboplatin, IP carboplatin, intraperitoneal carboplatin, or the IP cisplatin, round about 26 to 28 months. The hazard ratios were not significant, so there was no real benefit of giving either the intraperitoneal carboplatin schedule or the intraperitoneal cisplatin at a slightly lower than what was given in GOG 172 schedule. Of course, this trial had a more stringent CT follow-up, more than the previous two trials. So this is the progression-free survival for stage 2 to stage 3. This trial had only 10% of patients in stage 2. So more than 80% of patients were in stage 3. So almost 84% patients, the bulk of the patients in this trial were actually in stage 3. With no great difference in the progression-free survival, with a median of around 31 to 33 months in all three arms, for no gross residual disease as reported by the surgeon. And if you compare across studies, the GOG 172, the IV carboplatin arm, the progression-free survival was around 31.3 months, and here it was around 26.8 months, slightly lower. And the IP cisplatin arm had a much higher progression-free survival at 60 months in the GOG 172 arm. Remember that the IP cisplatin dose was definitely higher. It was 100 milligram per meter square vis-a-vis 75 milligram per meter square in this study, and it was only 23.8 months in this study. So dose reduction, differences of course are the dose reduction, and the paclitaxel in the conventional dose paclitaxel arm, the dose was 135 milligram per meter square in a 3-hour schedule, not in a 24-hour schedule. Bev was used for all arms from cycle 2 to cycle 22. And the second experimental arm was, of course, IP carboplatin with a dose-dense paclitaxel. So 1,560 patients participated with a median age of 58. And stage 2, as I said, was only 10% of patients. And there was no gross visible residual disease in 57% of patients as reported by the surgeon. Cycle completion. 90% of patients completed the 6 cycles of platinum in the IV carbo arm, and 90% in the IP carbo arm, and 84%. The cycle completion rates were definitely much higher than the GOG 172. That is one definite thing that was seen in the study. And crossover to IV only therapy happened in 16% in the IP carbo and 28% in the IP cisplatin arm. Coming to toxicities. The GI toxicities like fistula, etc., more than grade 3 was seen only in 5.3%, so much lower than what was reported in the GOG 172. The thrombocytopenia, hypertension was specifically high in the arm that had both IP cisplatin and IP bevacizumab, and hypertension was one of the reasons for discontinual or crossover also in this arm. So combination of cisplatin and bev did lead to more hypertensions. So the neurotoxicity, I'm not reading the numbers, but they were generally same across both the intraperitoneal chemotherapy arms and the IV chemotherapy arms. No major increased neurotoxicity signal seen in this trial. So survival for optimal and no residual disease participants will not be available for a few more years. Dose reduction of paclitaxel and cisplatin and crossover may have compromised efficacy in these trials. Dose-dense paclitaxel may have improved efficacy to allow us to abandon IP chemotherapy, but whether to combine both at this point is not. When you're increasing your results with an IP chemotherapy, do you need to add on a dose-dense paclitaxel, or the other way around? If you're going to give dose-dense chemotherapy with weekly paclitaxel, do you still need to have additional toxicity in the form of intraperitoneal chemotherapy? But still that answer is not clear. Neurotoxicity seems to be equal in all arms. Bevacizumab interactions could have clouded analysis because there was a lot of bevacizumab cisplatin arm hypertensions and more toxicities when both were given. And more number of CTs were there, so earlier progressions were picked up. So cannot recommend reduced dose IP at this doses now. Neurotoxicity is similar. Reserve changes for treatment till survival data is available. And as of now, we cannot recommend bevacizumab in optimal resected ovarian patients either with dose dense or with both the trials, either with dose dense or with IP chemotherapy in the first line. So this is all first line. So first line, both the trials show that we can't really recommend bevacizumab at this point of time in the first line because there is only some PFS benefit. So with that, so do the outcomes matter? The main thing in ovarian cancer seems to be what outcome we are looking at, whether we are looking at overall survival or progression-free survival, time to relapse. So what the outcome that we are measuring is really the important thing here. And as of now, from my take home from this is IP chemotherapy may be given in a selected subset of patients, but whether IP chemotherapy adds value when you're giving dose-dense chemotherapy is not clear. And bevacizumab from both the trials does not seem to be the way to go, at least in first line, especially if you're giving dose-dense paclitaxel, which is also cost-wise more sensible in our country. Thank you.